Hello. Well, today our topic is sodium and chloride metabolism and their disturbances. And in the next portion, we will discuss potassium and phosphate metabolism and their disturbances. Okay. So let's start off. Now, briefly discussing minerals. We have macro minerals and then we have micro minerals. Macro minerals are minerals that are required in like greater than 100 milligrams per day. The examples of that would be sodium, potassium, chloride, calcium, phosphate, and sulfur. Whereas microminerals are minerals which are required in less than 100 milligrams per day. And they will include iron, zinc, magnesium, selenium, iodine, copper, chromium, magnesium. Now, starting off with sodium. Sodium, as we all know, is the chief electrolyte, and we have it in the largest concentration in the extracellular fluid, which is the most abundant cation. It is also important in determining the water distribution across the cell membrane. And if we have an imbalance of sodium, so if we have low level of sodium, we will term it as hyponatremia, and high level of sodium will be termed as hypernatremia. Now, total body distribution of sodium. As we can see in extracellular fluid, we have about 140 millimoles per liter of sodium. And in ICS, we have about 10 millimoles per liter. Sources of sodium, as we all know, it is widely distributed in food material. And we can get a lot more sodium from the animal source compared to plant. But the major source is table salt. Apart from it, you can also get your sodium from cheese and butter. Now, what will be the daily requirements of sodium in adults? About 1 to 3.5 grams per day. In infants, 0.1 to 0.5 grams per day. And in children, about 0.3 to 2.5 grams per day. Absorption of sodium. There are sodium pumps which are present in the basal and the lateral plasma membrane of both intestinal and renal cells. And they actively pump sodium into the extracellular fluid. These pumps are called sodium potassium ATPase pump. Okay. And as the name suggests, that it requires ATP along with magnesium. And as mentioned earlier, we have a lot more sodium in the extracellular fluid, which is about 140 millimoles per liter, and in intracellular sodium concentration is 10 millimoles per liter. Now discussing the sodium potassium ATPase pump, it is a glycoprotein and has 2 alpha chain and 2 beta chain. Okay, and the activity of this pump depends upon, firstly, it requires sodium and potassium, and apart from it, ATP and magnesium, as we have previously mentioned. Okay, and the enzyme hydrolyzes a high energy phosphate bond of the ATP, and that is used for this energy purpose in order to transport the sodium from inside of the cell to the outside in the extracellular fluid, and similarly 2 potassium from the outside of the cell to the inside of the cell. And this process will take place simultaneously. As 3 sodiums are being thrown out, 2 potassium ions are also transported inside the cell. Okay, and in a minute, about 9,000 sodium ions and 6,000 potassium ions are transported. And this pump can be seen in a variety of places, like in fibers, muscle fibers, renal tubule, and intestinal mucosal cells. Now discussing the pump in further detail, it has 2 forms, E1 and E2 form. Okay, when it's in E1 form, you will have its ion binding site and phosphate binding site on the inside of the cell, on the cytoplasmic surface of the membrane. Okay, and on this ion binding site, which ions will bind? The sodium ions on the inside of the cell will bind to these ion binding sites. Okay, and after that, with the help of ATP, phosphorylation will take place and a conformational change will take place, and E1 will be converted into E2 form. Okay, Now, when it converts to E2 form, it does two things. Firstly, it will give binding sites for the potassium ion, where two potassium on the outside of the cell will bind, and at the same time, when it changes from E1 to E2 form, okay, it has a lower affinity for sodium. So what it does is it throws 3 sodium out, and at the same time, when it's in like E2 form, it will provide binding sites for 2 potassium ion on the outside of the cell. There 2 potassium ion will bind, and then dephosphorylation will take place, and again it will change from E2 form to E1 form again. And once it gets back to E1 form again, there again it has very low affinity for potassium, right? So it will make sure that it gets rid of those potassium ions. As soon as the potassium ions are on the inside, they will be transported towards the inside of the cell. This is how this pump works. You can appreciate that from this diagram here. If you start looking at it from the top left corner, there is this sodium binding site where the sodium ion will bind, and then with the help of the ATP, you will see a conformational change which will phosphorylate, and with this mechanism, as you can see from the third picture on the right top, sodium gets released outside of the cell, and potassium binds from the outside of the cell on those receptors, binding receptors. Okay, then dephosphorylation will take place, and it will lead to transportation of 2 potassium from outside of the cell to the inside of the cell. So basically, what happens is, as a result of this pump, 3 sodiums will be pushed outside the cell from the inside, and 2 potassium ion will be pumped inside the cell from the outside. Okay. Now, what are the inhibitors of these pumps? Certain drugs like guanine and digitalis. Okay, they cause dephosphorylation. As a result, this pump becomes inactive. Now, moving on to the excretion of sodium, about 25,000 millimole is filtered per day by the kidneys, of which tubular reabsorption is about 1%, and 100 to 200 millimole per day seen in the urine, and 70% of the filtered sodium is reabsorbed in the proximal tubule. Now, moving on to the functions of sodium. It has a very major role in maintaining fluid balance. Apart from it, it also has a role in neuromuscular excitability. Okay. It also maintains acid-base balance. It also maintains the viscosity of blood and the level of hydration of the plasma protein. And again, it also has a role in action potential. Okay. As we all know, when action potential takes place, we have this influx of sodium, and as a result of it, action potential takes place. It also has a role in maintaining the resting membrane potential. Now, moving on to the regulation of sodium. It is primarily regulated by 2 hormones, aldosterone and ANP. So what happens is, from aldosterone, we have decreased, when aldosterone comes into play, what it will do is it will lead to decreased urinary sodium excretion and increased absorption of sodium in the renal tubule at the expense of potassium. So what it does is it reabsorbs sodium and expels out potassium. Okay. This is how it maintains sodium balance. And the other hormone was ANP. And what that does is its role is somewhat opposite to that of aldosterone. Okay. It will cause increased excretion of sodium. Where on the contrary, what was aldosterone doing? It was preserving sodium at the expense of potassium. It was excreting out potassium and reabsorbing sodium. And ANP is basically excreting out sodium in urine. Now here we have a diagram which represents the renin-angiotensin-aldosterone system. As you can see, liver normally produces angiotensin. Okay. Now, firstly, let's just discuss what will lead to the release of renin. when you have a drop in your blood pressure or drop in the fluid volume, okay, then renin is released, and that renin will be released from the kidney, and it will convert angiotensin, which is released from the liver, into angiotensin 1. Then there's an enzyme that is released from the lungs called ACE, angiotensin converting enzyme. This will convert angiotensin 1 to angiotensin 2. Now this angiotensin 2 will work in like two ways. Firstly, it will go to the vessels and it will cause vasoconstriction. Okay. Now the second thing it will do is angiotensin 2 will go and act on the adrenal gland, and it will stimulate the release of aldosterone. And as we have previously discussed, what will aldosterone do? Aldosterone will increase the reabsorption of sodium at the expense of potassium. Okay. And in this way, sodium is retained. Now, there's another hormone as we discussed earlier called ANP, atrial natriuretic polypeptide. So it is released when the atria is stretched as a result of volume overload. Okay, and what will that do? Basically, it will dilate the afferent arteriole. Okay, and that will lead to an increased blood flow. Okay, diuresis. And then at the same time, it will also work on the collecting duct, and it will suppress the reabsorption of sodium in the collecting duct and other segment of the nephron, which will lead to excessive loss of sodium. Okay. Now moving on to chloride. And some proportion of it can be received from meats and vegetables and also from fluorinated water. Daily requirement of chloride is about 100 to 200 millimoles per day, and the primary source is table salt. As far as distribution is concerned, in whole blood we have about 250 milligrams per deciliter, in plasma 375, in CSF about 440, and in cells generally we have about 190 milligrams per 100 gram, and in muscles about 40 milligrams per 100 gram. Chloride is primarily absorbed from the small intestine, and so its absorption depends on the exchange process with the bicarbonate. Okay. Now, as far as excretion is concerned, in sweat and feces we lose about 5 millimoles of chloride per day, and from the kidney about 100 to 200 millimole per day, and 99% of it is reabsorbed by the proximal tubules. And plasma value of chloride is 96 to 106 milliequivalent per liter. Well, how is chloride regulated? Increase in blood volume will cause decreased reabsorption of chloride. Okay. And plasma value also depends upon sodium and bicarbonate. It is inversely proportional to bicarbonate and directly proportional to sodium. Okay. If we have increased bicarbonate, that will lead to decreased chloride in plasma. Similarly, decreased sodium is associated with decreased chloride, and increased sodium is associated with increased chloride, and decreased bicarbonate is associated with increased chloride. What are the functions of chloride? It helps in the production of hydrochloric acid in the stomach, and it also has a major role in chloride shift. Okay, what exactly is chloride shift? Basically, as the name suggests, it is an exchange of chloride and bicarbonate between plasma and the RBCs. Okay. Moving on to the disorders of sodium metabolism. Now, the normal sodium concentration of plasma is about 135 to 145 milliequivalent per liter. Okay. In hypernatremia, if we go above this normal value, we will label it as hypernatremia. Okay. What can be the causes of hypernatremia? One would be decrease in body water and increase in body sodium. Okay. It could be due to excessive consumption of sodium in diet. Apart from it, hypernatremia can also be caused by simple dehydration. As you lose fluid, the sodium concentration would automatically increase. Okay. And also in diabetes insipidus, what happens in this condition is one basically excessively urinates, which leads to excessive accumulation of sodium in the plasma. Okay. Apart from this, excess sodium intake will also cause hypernatremia. Mineralocorticoid excess, like aldosterone, if that is excess in your body, that will lead to excess reabsorption of sodium. Okay. Apart from it, steroid therapy may also cause hypernatremia. What will be the sign and symptoms of someone who is suffering from hypernatremia? Irritability, coma, restlessness, seizures. Apart from it, thrombosis, intracranial hemorrhage, dry mucous membrane, and poor skin turgor. Now, hyponatremia. Okay, hyponatremia is defined as a serum level of less than 135 milliequivalent per liter. If the sodium is less than 135 milliequivalent per liter, one would be labeled as hyponatremic. Okay, and it can be very severe if the level of sodium is below 125 milliequivalent per liter. So now, what will be the causes of hyponatremia? Diuretics medication can cause hyponatremia. Apart from it, excessive sweating, if someone is working out excessively. Chronic diarrhea or vomiting can also lead to loss of sodium. Kidney diseases will also ultimately result in hyponatremia. Apart from it, adrenal insufficiency, a different disease in which, let's say, you don't have enough aldosterone, that can also lead to hyponatremia. Apart from it, SIADH will also lead to hyponatremia. What will be the sign and symptoms of hyponatremia? Lethargy, headache, cerebral edema. Apart from it, muscle twitching, and seizures can also take place if the sodium is less than 110 milliequivalent per liter. The second part of the lecture, potassium and phosphate metabolism and their disturbances. Let's start. Moving on to the sources of potassium. A good source of potassium would include bananas, citrus juices, like it could be anything like orange, tomato, potatoes, apart from it, chicken and other meats. Now, you can also have potassium via different supplements that are available there in the market. Okay. Moving on to the distribution of potassium. It is the intracellular cation. Whole blood contains about 200 milligrams per deciliter. In plasma, we have about 20. In cells, we have about 450 milligrams per 100 gram. In muscle tissue, we have about 250 to 400 milligrams per 100 gram. In nerve tissue, 530 milligrams per 100 gram. As far as absorption is concerned, it is easily absorbed and then it enters into the cell. Then it is excreted in GIT, in saliva, gastric juices, bile, intestinal, and pancreatic juices. Okay. Now, intracellular concentration of potassium is 150, which is around about equal to that of sodium, which is outside the cell. So, intracellular sodium concentration is 150 milliequivalents per liter. And if you remember from the last lecture, sodium concentration outside the cell was around about 140 milliequivalents per liter. So, it is somewhat equal to that. Okay. Now, moving on to the normal plasma concentration. Normal plasma concentration of potassium is 3.5 to 5 milliequivalent per liter. And as we have previously discussed in the last lecture, the sodium potassium ATP response, it maintains this concentration. Okay. As far as the reabsorption is concerned, it is primarily reabsorbed from the proximal convoluted tubules of the kidney. And it is excreted or secreted from the distal convoluted tubules in exchange for sodium. Moving on to the functions of potassium. It maintains the body water balance between cells and body fluids. Apart from it, it is also involved in acid-base balance, also in maintaining normal cardiac rhythm, which is very important. Okay. As far as enzyme reactions are concerned, it works as a cofactor in pyruvate kinase. It also has a role in nerve conduction and neuromuscular excitability. Homeostasis of potassium is maintained by transcellular movement, and then gastrointestinal tract also has a role in homeostasis of potassium, and then we have the role of kidney, which also has a role in homeostasis of potassium. Now, as we all know, high intracellular concentration of potassium is maintained by uh, the sodium potassium ATPase pump. And what does that one do? It expels out the sodium from inside the cell to the outside, and it brings in two potassium from outside the cell to the inside the cell. Okay. Now, inside the cell, potassium is very important. It is essential for a number of enzyme reactions like pyruvate kinase, protein synthesis, glycogen synthesis, and it also has a role inside the cell in maintaining acid-base balance. Extracellular potassium, its concentration is roughly about 5 milliequivalents per liter of plasma, and it is very important in controlling neuromuscular excitability, okay, cardiac muscles, and apart from it, one important point, if we talk about insulin, whenever we administer someone insulin, we also need to keep a check on their potassium level. Because one function of insulin is that it will allow the entry of glucose inside the cell, but not just that, insulin will also stimulate the intracellular uptake of potassium. Okay. So whenever you're giving anyone very large amounts of insulin, so you need to keep a check on its potassium level as well. Transport of potassium across cell membrane. It can either be like through potassium hydrogen exchange or through bicarbonate potassium co-transport. Now, as far as gut is concerned, potassium from the diet and the gastrointestinal tract is reabsorbed in the small intestine, and then it is secreted in the colon and rectum in exchange for sodium. Okay, and now small amount of potassium is also excreted in the feces. And in conditions like chronic diarrhea and intestinal fistula, fecal excretion is increased. Excretion of potassium through urine is about 50 to 70 milliequivalents per liter, and potassium is primarily filtered by the glomerular, reabsorbed in the proximal convoluted tubule, and then it is actively secreted in the distal renal tubule in exchange for either hydrogen ions or sodium ions. Okay, and what keeps the check on this potassium level? We have aldosterone for that. Let's say if the concentration of potassium in the blood it rises by more than 1 milliequivalents per liter, and the normal value will be like the plasma value of potassium is 3.5 to 5.5. If it increases like more than 1 milliequivalent above this normal range, then aldosterone is secreted. And as we have previously discussed, what does aldosterone do? It will reabsorb sodium and it will excrete out potassium. Okay, so in this way, homeostasis of potassium is also maintained by the kidney. Now, what are the disorders of potassium metabolism? We have hypokalemia and hyperkalemia. Hypokalemia, as the name suggests, in this we will have low serum potassium level. Okay, and the patient might experience decreased heartbeats. Okay, and then we have hyperkalemia. If the potassium level is above the normal value, then we will label it as hyperkalemia. Okay, but usually this does not occur because the capacity of the kidney to excrete potassium is very high. So hyperkalemia seldom happens, but it can happen in conditions like renal failure and advanced dehydration and shock. Now, how to assess the patient? One should take careful history along with that physical examination, and then serum electrolytes, urinary electrolytes, and serum osmolarity. Now we will discuss hypokalemia. Okay, if someone has a serum potassium of less than 3 millimoles per liter, we will label it as hypokalemia. Okay, what will be the symptoms? The patient might experience muscular weakness, cardiac arrhythmias, and cardiac arrest. And As far as correction is concerned, if the patient is stable and he can tolerate oral diet, we might give him orange juice in order to correct this hypokalemia. But if the patient is not tolerating oral diet, then we will correct that hypokalemia with IV potassium. What will be the causes of hypokalemia? It could be either due to decreased intake of potassium or maybe loss of potassium from the gut in the cases of vomiting or diarrhea. Okay. Apart from it, increased urinary excretion may also cause hypokalemia, and redistribution from extracellular fluid to intracellular fluid, especially as I mentioned earlier, after the administration of insulin. If you administer someone insulin, someone who's diabetic, right, and large amount of insulin is administered, then what happens is it will also cause hypokalemia because all of the potassium will go inside the cell. Now, hypokalemia may also occur due to increased urinary excretion, right? Now, increased urinary excretion of potassium will be observed in hypoaldosteronism. Okay, as we all know, what does aldosterone do? Aldosterone basically excrete out potassium, so that can lead to hypokalemia. Apart from it, Cushing syndrome will also cause hypokalemia. Also in venotubular acidosis, in which there is an availability of hydrogen ion for exchange of potassium. Apart from it, ectopic ACTH production will also cause hypokalemia. High diuretics, again, they will also cause hypokalemia. And then there are certain drugs which will potentiate the action of aldosterone, like carbinoxolone, that will also cause hypokalemia, and also in Bartter syndrome, okay, in which we have secretion of renin and aldosterone is increased. Okay, so that will also cause hypokalemia. Now, what will be the symptoms of hypokalemia? As far as neuromuscular manifestations are concerned, patient might experience weakness, lethargy, depression, and cramp. As far as cardiac manifestations are concerned, patient might experience arrhythmias, hypertension, okay, and ECG changes. One will observe ST depression, flattened T waves, and prolonged PR interval. In renal manifestations, one will have inability to concentrate urine, okay, along with polyuria. Now moving on to hyperkalemia. There are three main causes of hyperkalemia due to impaired potassium excretion. One is advanced renal failure. Then we have marked volume depletion. And then we have hypoaldosteronism of any cause. As we all know, in hypoaldosteronism, like aldosterone itself was keeping a check on potassium level. Once we have diminished level or low level of hypoaldosterone, that will lead to hyperkalemia automatically. Okay, and clinical signs are very evident when we have potassium value of above 6.5 milliequivalent per liter. Now, what will be the causes of hyperkalemia? It may be due to increased intake of potassium, decreased urinary excretion of potassium, excessive administration of potassium once we are treating hypokalemia. Apart from it, redistribution of potassium from ICF to ECF may also cause hyperkalemia. Hyperkalemia can also result from decreased urinary potassium excretion in conditions like Addison disease. Again, also in Addison disease, we will have very less or no activity of aldosterone, which can cause hyperkalemia. Apart from it, congenital adrenal hyperplasia, again, mechanism will be the same because there will not be enough aldosterone, also in congenital adrenal hyperplasia. Redistribution of potassium from ICF to ECF, that can happen in severe tissue damage, injury, burns, hypoxia, failure of sodium pump, acidosis associated with urinary excretion of potassium. Now, what will be the clinical signs of hyperkalemia? In neuromuscular signs, you will have ascending paralysis, respiratory failure, and weakness. As far as ECG changes are concerned, peak T waves and flattened P waves will also be observed. Apart from it, widened QRS complex with deep S waves. will also be observed. Now we will move on to phosphate. As we all know, calcium is tightly regulated with phosphate in the body. Phosphate is an essential mineral and it mineralizes bone. It is also an important component of these high energy phosphate compounds, ATP. Okay, it also works as a second messenger. It also has an important role in cellular metabolism, and it is also a source of energy in cellular reactions, and it is also a component of the phospholipid membranes. So, almost 90% of the daily dietary phosphate is absorbed. Okay. Now, this absorption of phosphate is stimulated or regulated by both PTH, which is the parathyroid hormone, and vitamin D3. Okay. Phosphate, as we all know, is a constituent of bone and teeth, along with calcium. Okay. And uptake of phosphate by the kidney is sodium dependent. About 85% of phosphate is reabsorbed by the proximal convoluted tubule. Okay. Phosphate reabsorption is increased when dietary intake is reduced by a PTH mechanism. Okay. We will expand on this a little later. Basically, what happens is under normal circumstances, when is PTH released, parathyroid hormone is released when you have hypokalemia, right? When is PTH released? When you have hypokalemia. So, under normal circumstances, as far as the kidney is concerned, under the influence of PTH, calcium is reabsorbed and phosphate is excreted out. Normally, this is how PTH works. But only when dietary intake of phosphate is less, then by a PTH mechanism, reabsorption of phosphate from the kidney also increases. Okay. Now, the calcium phosphate ratio in diet will also affect the absorption of and excretion of phosphorus. Okay. Like if let's say one is excess in diet, the excretion of the other will increase. So this calcium phosphate ratio again is of importance. Now, what is the role of kidney? Phosphate uptake, as we have mentioned previously, is sodium dependent. About 85% of it is filtered and reabsorbed by the proximal tubule. Okay. Only when phosphate reabsorption increased, when dietary intake is reduced by a PTH dependent mechanism. Increased vitamin D increases phosphate absorption, and decreased vitamin D decreases phosphate absorption. Now, as I mentioned earlier, what was the stimulus of PTH? Hypokalemia was the stimulus for the release of PTH, right? So, under normal circumstances, when PTH is released, so it will work in the kidney in such a way that it will increase the reabsorption of calcium and increase the excretion or secretion of phosphate. Okay. In this way, it will also manage phosphate levels. Okay. And as far as vitamin D is concerned, vitamin D will increase the absorption of both calcium and phosphate, both of it from the gut. Okay. What are the functions of phosphate? Phosphate, as we all know, is the constituent of bone and teeth. Okay. It also has a role in energy transfer. These high energy phosphate, ATP, and all, phosphate has a role in that. Apart from it, phosphate buffers again are an important buffer of the body. So in that way, they also maintain the acid-base balance. It also has a role in enzyme actions. Okay. And apart from it, phosphate are also like a constituents of phospholipids, nucleotides, nucleic acid, lipoprotein, phosphoprotein, and normal serum phosphate level is 3 to 4.5 milligram per deciliter. Moving on to the RDA for adults, for adults 19-year-old or older, we have about 700 milligram per day, and for children 9 to 18 years old, we have 1250 milligram per day. Moving on to the sources, dairy, red meat, poultry, seafood, legumes and nuts are rich source of phosphate. Clinical condition related to phosphate. In primary hyperparathyroidism, we will have increased calcium and decreased phosphate. Why? Because we have to keep one thing in mind. What was the primary function of parathyroid hormone as far as kidney was concerned? That was to reabsorb calcium and excrete out phosphate. So for that reason, calcium is increased and phosphate is decreased. Okay. Now in malignancy, both calcium and phosphate will be increased. Similarly, in hypoparathyroidism, what will be the effect? Decreased calcium and increased phosphate. Why again? Because the same reason, because what was the function of parathyroid hormone? The function of parathyroid hormone was, as far as kidney was concerned, that it was reabsorbing calcium and excreting out phosphate. So if parathyroid hormone is not there anymore, what will that lead to? That will lead to decreased calcium and increased phosphate, as you can see here, right? Now, as far as vitamin D deficiency is concerned, again, as I mentioned earlier, with respect to phosphate, what was the function of vitamin D? Vitamin D was making sure that it absorbed both calcium and vitamin D from the gut intestine, right? So if, let's say, vitamin D is deficient, what will that lead to? That will obviously lead to deficiency of both calcium and phosphate. Okay. Moving on to hypophosphatemia. What will be the causes of hypophosphatemia? Alcoholism is a cause, apart from it, burns. Then we have respiratory alkalosis, hyperparathyroidism, vitamin D deficiency, hypothyroidism, and Cushing syndrome. Now, what are the symptoms? Muscle weakness, softening or weakening of the bones, depletion of muscle, altered mental state, seizures, numbness, heart failure, and muscle pain. Now, moving on to hyperphosphatemia. What will be the causes? Renal failure, hypoparathyroidism, high vitamin D level, and diabetic ketoacidosis. What will be the symptoms? Usually it is asymptomatic unless hypocalcemia occurs. Then you will have the symptoms of hypocalcemia. Okay. So this is all regarding phosphate and potassium. Okay. Just keep a few points in mind as far as parathyroid hormone was concerned. With respect to phosphate, who was maintaining the balance of phosphate? Firstly, was vitamin D. And what was vitamin D doing? It was making sure that it absorbed both calcium and phosphate. And what was PTH doing? PTH was making sure, under normal circumstances, that it was absorbing calcium and excreting out phosphate. Okay. Only if one's diet is deficient in phosphate, then due to a PTH dependent mechanism, absorption of phosphate might also increase from the kidney. Okay, only in this one particular case. But apart from it, under normal circumstances, what does PTH do? PTH basically reabsorbs calcium from the kidney and excrete out phosphate. Okay, this will be all regarding phosphate and potassium. Okay, thank you.